Premature rupture of membrane (PROM). This is defined as rupture of membrane before onset of labor. Another entity is known as PPROM, preterm PROM. This is defined as rupture of membrane before 37 weeks. Now, what are the risk factors? Previous history of PROM, infections, polyhydramnios, multifetal pregnancy. Now, polyhydramnios and multifetal pregnancy cause PROM due to overdistension. Other risk factors are acute trauma, antepartum hemorrhage, and smoking. Now remember, smoking is protective in preeclampsia. Now pathogenesis of PROM. Three entities: infection, inflammation, and mechanical stress. They both decrease tensile strength of membranes, leading to PROM. Now presentation. Presentation of PROM will be: patient comes with complaint of leakage of fluid. The fluid can be colorless or clear. This will be the chief complaint. Other presentation can be presence or absence of uterine contraction. Complications can be cord prolapse, chorioamnionitis, abruption of placenta. Now, diagnosis of PROM. We can confirm the diagnosis by pars speculum examination. On pars speculum examination, we can see clear fluid coming from os and pooling in the vagina. If on pars speculum examination we don't see fluid coming out, we ask the patient to cough and we can press on the fundus. If still we don't see any fluid coming out, we can perform other tests. First is nitrazine paper test. We see here the pH change. Now the normal vaginal pH in pregnancy is 4. In cases of rupture of membrane, the amniotic fluid pH becomes 7 to 7.3. Another test is rapid slide test. This is a bedside test, but it is expensive and not easily available. In case of active PROM, IGF BP1 detection is done. IGF binding protein 1. In case of amnisure, PAM-G1 detection is done. Placenta alpha microglobulin protein assay. We can also see the furning of secretions in vagina. Vaginal secretions in pregnancy under effect of progesterone don't show furning. If there is leakage of amniotic fluid and we make smear from secretions, it will show furning. This image shows the delicate furning of amniotic fluid. Another test is dye instillation. Dye used is indigo caramine. This is an invasive test. On ultrasound, we can see oligohydramnios. The other findings can be malpresentations. Now on per abdomen examination, we can see that the fundal height will be less than the period of gestation. Uterine contraction can be present or absent. Fetal heart rate auscultated. Fetal distress can be present due to cord prolapse or cord compression. There can also be malpresentations. Now the clinical course of PROM. Most of these women deliver within a week. This is the most common outcome because PROM leads to release of prostaglandins that initiates delivery. Other outcomes can be placental abruption, chorioamnionitis, or cord prolapse. Now the management of PROM. It depends on the period of gestation. If the period of gestation is less than 34 weeks and there are no complications, that is, no chorioamnionitis, no cord prolapse, no distress, then we can give steroids. First we will give steroids. If uterine contractions are present, then tocolytics are given. Antibiotics are given for prophylaxis of group B strep. Fetal monitoring is done by fetal heart rate auscultation, non-stress test or biophysical profile, and periodic ultrasound. Maternal monitoring is done by vitals, pulse rate or temperature monitoring, TLC counts, and check for any foul smelling discharge. Now, if the period of gestation is more than 34 weeks and no complications are present, we can give steroids till 36 plus 6 weeks. Here, no tocolytics are given. Antibiotics are given for group B strep. We monitor the fetus and the mother. Termination of pregnancy is done at or more than 37 weeks. In case of prolonged rupture of membrane, that is more than 18 hours, patient should receive antibiotics. Now we will see chorioamnionitis. This is defined as intrauterine infection of placenta and membranes. Cervicovaginal flora migrate to the uterus and cause this infection. This is a polymicrobial infection. The diagnosis is clinical. If fever more than or equal to 39 degrees Celsius or 38 to 38.9 on 2 occasions is seen, and if she develops any of the following: fetal heart rate more than 160 per minute lasting for more than 10 minutes, where the normal fetal heart rate is 110 to 160 beats per minute, WBC count is more than 15,000, and purulent appearing fluid from os. To confirm the diagnosis, amniotic fluid should be sampled for gram stain or culture, and on histopathological examination, evidence of infection in placenta or fetal membrane. Other findings in chorioamnionitis can be maternal tachycardia or fundal tenderness, but these are not mandatory for diagnosis. Now, complications: maternal and fetal. Maternal complications are abnormal labor, postpartum hemorrhage, postpartum endometritis, septic pelvic thrombophlebitis, that is thrombosis of ovarian vessels. Fetal complications are neonatal sepsis, perinatal death, meningitis, pneumonia. Now, management of chorioamnionitis. There is no role of conservative management. We have to deliver the baby, and broad spectrum antibiotics are given. Chorioamnionitis is a contraindication for tocolytic and contraindication for steroids. Preferred mode of delivery is vaginal. C-section is reserved for obstetric indication, that is placenta previa, severe fetal distress. Now, cord prolapse. In this case, the cord slips out, protrudes into vagina or protrude outside vagina. It is an obstetric emergency. Cord can get compressed by the presenting part during labor. Sudden temperature change occurs, leading to intense vasospasm of cord, causing fetal hypoxia. Clinical presentation: severe and prolonged fetal bradycardia, most common presentation. Variable repeated deceleration. Risk factors are polyhydramnios, premature rupture of membrane, malpresentation. Highest risk is associated with transverse lie, breech presentation, twin pregnancy, external cephalic version. Management of cord prolapse is emergency C-section. Indications of vaginal delivery are: if fetal heart rate is absent, indicating intrauterine death. In case of fully dilated cervix, then we can do instrumental delivery, that is vacuum extraction. Now, the management algorithm of cord prolapse. First, call for help. Left lateral positioning of female, that decreases cord compression. Give oxygen by mask. If cord is lying outside vagina, gently hold the cord with moist gaze and put into vagina. Now we should do per vaginal examination and look for dilation of cervix during labor. If fully dilated, we can undergo instrumental delivery. We can manually lift up the presenting part away from cord during PV examination. Now, while shifting to the OT to improve fetal outcome, we should retrograde, fill the bladder, put the patient in Trendelenburg position, that is, head end is low and buttocks are lifted up, knee chest position. These three maneuvers are to prevent compression of cord. Then we can do C-section. In case of cord prolapse, there is no time for spinal or epidural anesthesia. We have to give general anesthesia. General anesthesia is also given in shock and severe fetal distress because it can lead to cord prolapse and vasa previa. Thank you.